Welcome back to Ace the AMC. We have another AMC style question. This question is from our partners Ace the Exam. I'll give you a moment to pause, answer the question, and we'll get into the explanation. So let's now break down this question step by step. We're given a 25-year-old male with uncontrolled hypertension despite being on losartan for 6 months. So straight away, we got a young male and we've got this resistant hypertension. So we should automatically start thinking about a secondary cause of hypertension rather than a primary or the central hypertension. So in this stem, his blood pressure is 160/98, which confirms poor control. He also has bilateral pitting pedal edema. So this is suggesting some sort of sodium or water retention. His ECG shows normal sinus rhythm with left axis deviation, and this is consistent with a picture or scenario of long-standing hypertension. But there's no evidence of an acute cardiac cause for his chest pain currently. So the key thing right now we need to consider is that he's been prescribed furosemide, which is a loop diuretic, and shortly after he's been prescribed this medication, he's starting to feel funny and cannot move his lower limbs. So this should immediately make us think of some sort of hypokalemic cause of muscular weakness or paralysis. So we then go to check the labs. His glucose is 120, which is normal. Sodium is also within normal range, it's 138. However, his potassium is 2.9, which is quite low. So the patient has developed a symptomatic hypokalemia, which has been unmasked by the use of that furosemide. So what this shows is that he already had an underlying potassium wasting issue, and the furosemide just simply pushed it over the edge in layman's terms. So now we ask ourselves, what's causing the hypertension alongside his potassium wasting? What are the options? The scenario that fits best in this situation would be primary aldosteronism. So primary aldosteronism fits perfectly here because we've got the sodium and water retention, which is indicated by his hypertension and his edema, and we've also got potassium loss. Important to note that losartan does not block aldosterone directly. So in an instance of primary aldosteronism, the blood pressure often remains uncontrolled despite us still giving an ARB. So diuretics can then precipitate the severe hypokalemia, which is what then led to him not being able to move and the paralysis he experienced in this case. So we just submit the option now, and so we've got that question right. So now let's quickly rule out the other options we had in this stem. So renal artery stenosis, this is not correct in this case because this usually causes renal dysfunction or Brewitt's, which would be heard. However, these weren't present in our stem. Pheochromocytoma, this is not the case because we would have episodic headaches, palpitations, sweating. These would be signs that would indicate a pheochromocytoma. Also, this option doesn't explain the hypokalemia, so it's not the best fit for this case. Cushing syndrome, this is not the best fit because we would have seen hyperglycemia, which is not the case in this stem, and we would also see features of Cushingoid habitus or features. Primary hyperparathyroidism, this is not the option because this would cause hypercalcemia, not hypokalemia. So overall, the correct answer for this stem was primary aldosteronism. There's an explanation there. So that concludes the video. Hope you guys gained a lot out of this explanation. If you guys have any questions, leave them in the comments. And if you want more questions such as these, check out the Ace the Exam website. See you guys in the next one.